Welcome back, class. Today we transition our focus to our newest module, Navigating the Landscape of Geriatric Nursing. Understanding how to leverage specific resources and implement clinical best practices is fundamental to ensuring patient safety and elevating the quality of care for our older adults. Let's dive into how these evidence-based strategies empower us to provide the excellence our patients deserve. The primary focus here is recognizing that the new landscape of geriatric nursing requires a fundamental shift in our clinical mindset, moving away from a purely acute, cure-oriented model toward one that prioritizes functional status and quality of life. As we begin this journey into the foundations of geriatrics, we must ask ourselves, why is an 80-year-old patient vastly different from a 50-year-old with the same diagnosis? The compass we use to navigate this landscape is built upon understanding the heterogeneity of aging. Unlike younger populations, older adults do not follow a standardized physiological path. We are looking at a population where the normal baseline is highly individualized. For the geriatric nurse, the most critical question isn't just, what is the diagnosis, but rather, how does this diagnosis impact the patient's ability to perform activities of daily living? In this new landscape, we must confront the Silver Tsunami, the unprecedented demographic shift that demands a workforce skilled in managing multimorbidity and polypharmacy. When we look at the older adult, we are seeing the intersection of physiological changes, such as decreased homeostatic reserve, and psychosocial transitions, like the loss of peers or a change in living environment. For the NCLEX and your clinical rotations, remember that aging is not a disease. While organ systems lose reserve, a concept known as homeostenosis, pathology is never normal just because a patient is old. If an older patient presents with sudden confusion, we do not dismiss it as dementia because of their age. We investigate for an acute underlying cause, like a urinary tract infection or hypoxia. Clinical Pearl. Always establish a patient's functional baseline upon admission. To provide safe care, you must know what they could do yesterday to identify the subtle, atypical presentations of illness today. In geriatrics, a change in function is often the first sign of a medical emergency. Looking at this exponential growth curve, we are witnessing the Silver Tsunami in real time. By the year 2050, the population of older adults in the U.S. is projected to reach 88 million, nearly quadrupling since the 1970s. This demographic shift isn't just a statistical trend, it is a fundamental transformation of our healthcare delivery system. Geriatric care is no longer a specialty elective, it is the core of modern nursing practice. Why is this shift so critical for your clinical judgment? Because increased longevity does not always equate to increased health span. As we live longer, we face a higher prevalence of multimorbidity and the complex interplay of chronic conditions. We are moving away from the traditional medical model of treating one acute illness at a time and toward a holistic, evidence-based approach that prioritizes functional independence. How does this change our nursing interventions? In a younger patient, a high fever is a classic sign of infection. But in our 88 million strong aging population, you must look deeper. Due to decreased physiologic reserve, an older adult may not mount a fever at all. Instead, their white flag of distress might be a sudden onset of confusion, a newfound weakness, or a fall. If we wait for textbook symptoms, we have waited too long. From a psychosocial perspective, we must address the geriatric syndromes, falls, delirium, and polypharmacy that can strip a patient of their autonomy. On the NCLEX and in the field, your priority is often the preservation of the patient's ability to perform activities of daily living. In geriatric nursing, the goal isn't just to add years to life, but to add quality to those years. Clinical Pearl. Always monitor for atypical presentation. In the older adult, the first sign of a physical illness, like a UTI or pneumonia, is frequently acute confusion. Never dismiss a change in mental status as normal aging. It is a medical emergency until proven otherwise. Looking at this image, we are reminded that in geriatric nursing, our primary challenge is to strip away the clinical invisibility that often comes with age. When the text says this is not just a number, it is a direct call to combat ageism, the systematic stereotyping of and discrimination against people because they are old. In your practice, why is it critical to look beyond the chronological age? Because the number does not tell you the patient's functional reserve, their cognitive baseline, or their personal resilience. The individual in this clinical scenario is engaged in gardening, which represents a high level of instrumental activities of daily living. According to the Williams curriculum, maintaining these complex tasks is a primary indicator of cognitive health and physical independence. To provide our best, we must transition from a traditional medical model, which focuses on what is broken, to a strengths-based approach. This means documenting what the patient can do, such as these fine motor tasks, and incorporating those strengths into the plan of care to prevent the hazards of hospitalization, like functional decline and learned helplessness. NCLEX focus. When you are prioritizing care for the older adult, remember that psychosocial integrity is just as vital as physiological adaptation. If a patient is deprived of their story and their autonomy, they are at a significantly higher risk for geriatric failure to thrive. Providing our best means performing a comprehensive assessment that uses the SPICES tool while simultaneously honoring the patient's life history and values. Clinical Pearl. Use narrative nursing during your initial assessment. Instead of only asking, "Do you have pain?" ask, "What is a typical day like for you at home?" This reveals the patient's functional baseline and provides the motivation needed for rehabilitation. Always remember, we do not treat a hip fracture in room 402. We treat a gardener who happens to have a hip fracture. Mission critical focus. Preserve the personhood to preserve the health. The primary focus here is the invisible barrier that often stands between a nurse and their patient: ageism. In geriatric nursing, ageism is not merely a social faux pas. It is a significant clinical hazard that directly correlates with poor patient outcomes. When we define ageism as discrimination based solely on age, we must recognize its most dangerous form in the clinical setting: therapeutic nihilism. This is the erroneous belief that patients' decline is just because they are old, which often leads to the underdiagnosis and undertreatment of manageable conditions. Why is this mindset critical for the older adult? Consider a patient presenting with new onset fatigue or cognitive slowing. If a nurse views this through the lens of ageism, they might dismiss it as normal aging. However, a skilled geriatric nurse knows to look beyond the age to investigate clinical possibilities like hypothyroidism, depression, or an adverse drug reaction. When we succumb to ageist stereotypes, we fail to perform the comprehensive assessments our patients deserve. From a psychosocial perspective, ageism erodes the therapeutic relationship. When patients feel they are being written off or treated as a burden, they are less likely to disclose symptoms or adhere to treatment plans. This creates a measurable negative impact on health outcomes, often manifesting as increased hospital readmissions and decreased functional status. How does this change our nursing intervention? It means our first intervention is always a self-check for bias. NCLEX focus. On your licensure exam and in clinical practice, communication is a high priority area. Avoid elder speak, the use of high-pitched, slow, or overly simplified speech often used with children. Studies show that elder speak increases resistance to care in patients with dementia and lowers self-esteem in cognitively intact adults. Always address the patient directly, using their formal name unless invited otherwise. Clinical Pearl. To see past the fog, always assume the patient has the capacity for improvement and autonomy until a clinical assessment proves otherwise. Always prioritize the assessment of acute changes over the assumption of chronic decline, treating the person, not the birth date. Looking at this visual representation of our true north, we are centering our practice on the core philosophy of person-centered care. In geriatric nursing, the goal isn't just the absence of disease, but the optimization of the individual's quality of life based on their definition of what that looks like. The text emphasizes moving beyond stereotypes. In clinical practice, we call this the active combating of ageism. Why is this distinction so critical for our nursing assessment? If we assume a patient is just confused because they are old, we will inevitably miss the early, subtle markers of acute delirium or an underlying infection like a UTI, both of which require immediate clinical intervention. We must treat every patient as a unique physiological entity, not as a collection of normal aging symptoms. Notice the nurse's positioning in the image. She is at eye level, maintaining focused engagement, and utilizing therapeutic touch. This is a primary nursing intervention. For the older adult who may be experiencing sensory losses or social isolation, this physical presence builds the trust necessary to elicit an accurate health history. How does this change our nursing intervention? It shifts us from doing to the patient to partnering with the patient. From an NCLEX focus perspective, you must prioritize the patient's autonomy. When a question asks for the priority action in care planning, you must look for the answer that incorporates the patient's individualized needs, values, and preferences. Nursing care that ignores the patient's values is technically proficient, but clinically incomplete. We are not just managing chronic conditions, we are preserving the dignity of a human life. Clinical Pearl. Always use the teach-back method to validate that your compassionate care is actually being understood. Never assume understanding based on a nod of the head. Ask the patient, "To make sure I explain this clearly, can you tell me in your own words how you will take this medication at home?" This ensures that our true north is actually guiding the patient towards safety and health literacy. Looking at the 4M's framework, what matters, medication, mentation, and mobility, we are moving away from traditional disease-centric care toward a holistic, evidence-based approach that prioritizes the functional life of the older adult. This model, developed by the Institute for Healthcare Improvement, isn't just a checklist. It is a clinical compass meant to guide every interaction you have at the bedside. Why do we start with what matters? In geriatric nursing, clinical success is not just the absence of disease, it is the alignment of care with the patient's specific health outcome goals and care preferences. Ask yourself, does this aggressive treatment plan align with the patient's desire for quality of life at home, or are we simply treating a lab value? Always assess and act on what matters to the patient to ensure we are not over-medicalizing the end-of-life process. When we address medication, we must consider the physiological changes of aging, specifically decreased renal clearance and hepatic metabolism. As a nurse, you are the last line of defense against polypharmacy. Why is a specific drug on the Beers criteria list high risk for this patient? High-risk medications can lead to adverse drug events that directly impair the other 3M's. For example, an inappropriate sedative will cloud mentation, which then increases fall risk and halts mobility. Speaking of mentation, we are looking at the 3Ds: delirium, dementia, and depression. Delirium is a medical emergency and is often the first sign of an underlying infection or metabolic imbalance in the older adult. How does our nursing environment contribute to or prevent cognitive decline? We must prioritize orientation and sleep hygiene to prevent the ICU psychosis that often sidelines recovery. Finally, we look at mobility. We know that an older adult can lose significant muscle mass and functional independence after only 48 hours of bed rest. Our goal is to ensure they move safely every day to maintain function. If we don't prioritize mobility, we are essentially prescribing disability. NCLEX focus. Remember that these 4 elements are interdependent. A change in one often triggers a cascade in the others. When you see a question regarding a new onset of confusion, your first nursing action should involve checking for new medications or signs of physical decline that limit mobility. Clinical Pearl. Use the teach-back method when discussing what matters and medications. If a patient cannot explain why they are taking a high-risk medication, the risk for an adverse event at home increases exponentially. Safety starts with patient understanding. Looking at the north of our geriatric compass, what matters is not just a polite inquiry. It is the cornerstone of the age-friendly health system's 4M's framework. In geriatric nursing, we must shift our clinical focus from what is the matter with you to what matters to you. Why is this distinction so critical for the older adult? As we age, physiologic reserves decrease, and the burden of chronic disease often increases. If we focus solely on curing or fixing a lab value, we may inadvertently choose interventions that destroy the patient's quality of life. For instance, an aggressive chemotherapy regimen might technically shrink a tumor, but if it renders the patient bedbound and unable to recognize their family, have we truly met their goals? When you look at the clinical interaction pictured here, notice the positioning. The nurse is at eye level, engaging in active listening with both the patient and their support system. This is where we identify specific health outcome goals. Are they prioritizing functional independence? Are they focused on symptom management? This information must then drive the other 3M's: medication, mentation, and mobility. On the NCLEX and in practice, remember that the nurse's primary role is patient advocacy. This involves ensuring that advanced directives and POLST are not just checked boxes in the chart, but are living documents that reflect the patient's current, informed wishes. This is the very definition of person-centered practice. How does this change our nursing intervention? It means we don't just do for the patient, we do with the patient, aligning every pill we give and every therapy we schedule with their stated north. Clinical Pearl. Start your shift by asking the patient, what is the one thing about your health or care that is most important to you today? Documenting this answer ensures the entire interdisciplinary team stays aligned with the patient's true compass.
Looking at the medication component of our age-friendly framework, we must first ask the most critical clinical question: is this medication truly necessary? In geriatric nursing, our primary goal is to prevent the prescribing cascade, where a new drug is ordered solely to treat the side effects of an existing one. This is how polypharmacy begins to compromise patient safety. Age-related changes in pharmacokinetics, how the body processes the drug, and pharmacodynamics, how the drug affects the body, require absolute precision. Why is this so vital? As our patients age, they experience a decrease in total body water and an increase in body fat percentage. This means lipid-soluble drugs, such as many sedatives and psychotropics, can have a significantly prolonged half-life, lingering in the adipose tissue and staying in the system far longer than intended. Furthermore, a natural decline in the glomerular filtration rate means we must monitor renal function constantly, as decreased clearance is a primary driver of toxicity. When we evaluate a medication profile, we are looking for interference with the other 3 M's. We must ask, does this antihypertensive cause orthostatic hypotension that leads to a fall, impairing mobility? Does this antihistamine or bladder antispasmodic induce acute confusion or delirium, affecting mentation? If a medication causes such profound lethargy that a patient can no longer engage in their hobbies, it is directly interfering with what matters to them. For your NCLEX and clinical rotations, you must prioritize the Beers criteria. This is the gold standard list of potentially inappropriate medications for older adults. You should be prepared to question orders for medications with high anticholinergic properties or long-acting benzodiazepines in the geriatric population. Clinical Pearl. Always advocate for the principle of start low and go slow. When performing a medication reconciliation, use the teach-back method to ensure the patient understands not just how to take the pill, but why they are taking it, and what specific side effects require an immediate call to the provider. Looking at the foundational principles of safe medication administration, we must recognize that for the geriatric patient, there is zero margin for error. In your textbook, Basic Geriatric Nursing, Patricia Williams emphasizes that precision in calculation is a core competency because our older adults often possess a significantly reduced physiological reserve. Why does a small calculation error lead to catastrophic outcomes in the elderly versus a younger adult? It comes down to pharmacokinetics. With age-related declines in glomerular filtration rate and hepatic metabolism, medications remain in the system longer, dramatically increasing the risk of toxicity. When we look at the formula displayed, essentially the desired over have method, we are building a mental scaffold to prevent medication creep, where small inaccuracies compound into life-threatening adverse drug events. In the clinical setting, you aren't just doing math. You are acting as the final safety filter between the prescriber's intent and the patient's bloodstream. How does a simple decimal point error in a potent diuretic or a cardiac glycoside affect an 88-year-old with a low body mass index? The result is rarely a simple mistake. It is often a sentinel event. For the NCLEX, you must be able to move fluidly between units of measure. However, the priority nursing action is always to verify the 5 rights and ensure the dose is appropriate for the patient's age and renal function before the needle ever touches the vial. Clinical Pearl, always perform your calculations in a no interruption zone. If a colleague or family member interrupts you during a med-math calculation, stop, clear your screen or paper, and start the calculation from the beginning to ensure patient safety. The primary focus here is mentation, a critical pillar in age-friendly care that requires us to look beyond the surface of a patient's behavior. When we talk about mentation in geriatric nursing, we are navigating the complex intersection of the 3 Ds: dementia, delirium, and depression. Why is this distinction so vital for our clinical practice? Because while they may look similar, confusion, withdrawal, or agitation,
their pathophysiology and our nursing interventions are vastly different. When assessing an older adult, we must first ask, is this change acute or chronic? Delirium is a medical emergency. It is an acute, fluctuating change in mental status, often triggered by underlying physiologic stressors, like a urinary tract infection, dehydration, or polypharmacy. Unlike dementia, which is a slow, progressive decline, delirium can often be reversed if we identify the cause quickly. If we miss the signs of delirium and mislabel it as dementia, we are failing to treat a potentially life-threatening condition. Then we consider depression. Why is it so frequently underdiagnosed in the elderly? Often, both clinicians and families mistakenly view sadness or apathy as a normal part of aging. It is not. Depression can manifest as pseudo-dementia, where the patient appears cognitively impaired because they are too overwhelmed or lethargic to engage with assessment tasks. Our role is to use validated tools, like the Geriatric Depression Scale, to ensure these patients receive the mood-stabilizing support they need to maintain their quality of life. Lastly, we address dementia. As the slide notes, a person's cognitive state is not their identity. In geriatric nursing, our priority is dignity and safety. We must move away from correcting a patient with advanced memory loss, which only increases agitation, and instead move towards validation therapy and creating a failure-free environment. NCLEX focus. You must be able to differentiate the 3Ds. Remember, delirium has an abrupt onset and impaired consciousness. Dementia has a slow onset and clear consciousness until late stages. Depression involves a cognitive slowing, but the patient is usually oriented. Clinical Pearl. Always establish a cognitive baseline with the family upon admission. Ask, how was their memory and orientation 1 week ago? If the confusion is new, assess for infection or medication side effects immediately.
Looking at the mobility component of the age-friendly health systems framework, we must recognize that for the older adult, movement is synonymous with independence. When a patient loses the ability to ambulate or transfer safely, they often lose their sense of self and their ability to participate in what matters to them. Why is this assessment finding critical for the older adult? Because in the geriatric population, even 48 hours of bed rest can lead to significant muscle atrophy and a permanent loss of functional baseline, a phenomenon we call deconditioning. As nurses, we are the frontline defense against this decline. Every interaction, whether you are entering the room to deliver medication or performing a skin assessment, is a mobility opportunity. Ask yourself, is the patient in the correct footwear? Is their walker at the appropriate height? We must shift our mindset from keeping the patient in bed to prevent falls to moving the patient safely to prevent disability. This requires a clinical balance. We utilize evidence-based tools like the timed up and go test to quantify gait and balance, but we also use our clinical intuition to encourage incremental movement. NCLEX focus. Remember that early ambulation is the primary nursing intervention to prevent the big 3 complications of immobility in seniors: pneumonia, venous thromboembolism, and pressure injuries. Clinical Pearl. Always employ the teach-back method when instructing a patient on a new mobility aid. Have them demonstrate the sequence: walker, weak leg, strong leg. Never allow a patient to use a walker to pull themselves up from a seated position, as this creates a center of gravity imbalance that leads to backward falls. They must push from the chair surface first. Looking at the transition from classroom theory to the bedside, we must realize that clinical judgment is not an innate trait, but a developed skill. The Understanding Aging worksheet serves as your diagnostic compass. In geriatric nursing, we often encounter the knowledge-action gap. Knowing the physiological changes of aging is one thing, but applying them to a complex patient with multi-system comorbidities is where nursing excellence is forged. Why do we utilize the 4Ms framework? What matters, medication, mentation, and mobility as our guide? Because older adults do not present with textbook symptoms. A decline in mobility might not just be a musculoskeletal issue. It could be a side effect of a new medication or a symptom of declining mentation due to an underlying infection. How does this change our nursing intervention? It forces us to move beyond the primary complaint and look at the patient holistically.
From an NCLEX focus, you must be able to differentiate between normal age-related physiological changes and pathological ones. For example, while a decreased glomerular filtration rate is a normal part of aging, renal failure is not. When you fill out your worksheet, you are performing a functional assessment. You are asking, how does this patient's unique aging process affect their ability to remain independent? The primary focus here is the prioritization of safety. When we address what matters, we align our clinical goals with the patient's psychosocial needs. This reduces the risk of hospital-acquired delirium and functional decline. If we ignore what matters to the patient, our clinical successes may actually lead to a lower quality of life. Clinical Pearl. Always use the teach-back method when discussing the 4Ms with an older adult. Ensure they can explain their medications and mobility plan in their own words to confirm understanding and prevent readmission. Looking at the 4Ms framework, we transition from abstract theory to the bedside reality of caring for the older adult. This worksheet serves as a clinical roadmap to ensure we are practicing within an age-friendly health system. Why is this framework so vital for our practice? Because it shifts our focus from what is the matter with you to what matters to you. The primary focus here is what matters. In geriatric nursing, patient autonomy is paramount. We must align the plan of care with the patient's specific health goals and care preferences. For example, is their goal to return home to garden, or is it simply to achieve adequate pain control? If we don't document their core values, our clinical interventions may actually work against their quality of life. When assessing mobility, we are looking at more than just a gait belt. We are evaluating the patient's ability to move safely and maintain their independence. Remember, bed rest is not a requisite of aging. In fact, just a few days of immobility in the hospital can lead to permanent functional decline in an older adult. How does our assessment of their strength and balance today prevent a catastrophic fall tomorrow? Reviewing medication requires us to be pharmaceutical detectives. We must constantly screen for polypharmacy and medications listed on the Beers criteria. Are we seeing a new symptom, or are we seeing a side effect of a drug? The prescribing cascade, where a second medication is given to treat the side effects of the first, is a significant risk factor for adverse events and falls in our patient population. Finally, considering mentation involves the critical task of differentiating between the 3 Ds: delirium, dementia, and depression. While dementia is chronic and progressive, delirium is a medical emergency. If you notice an acute change in mental status, you must immediately assess for underlying causes like UTIs, dehydration, or medication toxicity. Clinical Pearl. When filling out the What Matters section, use the teach-back method. Ask the patient, to make sure I have this right, can you tell me what your biggest priority is for your recovery today? This ensures the care plan is truly collaborative and increases patient safety during transitions of care. Looking at the foundational principles within Patricia Williams's basic geriatric nursing, we see a shift from rote memorization toward the development of high-level clinical judgment. Why is the shift so critical for the geriatric population? Because the older adult rarely presents with the textbook symptoms we see in younger cohorts. The inclusion of learning features connected by case examples is designed to address the complexity of cascade iatrogenesis, where one minor intervention in an older adult can lead to a series of escalating complications. For example, when an older adult is hospitalized for a hip fracture, a case study will challenge you to manage not just the bone, but the secondary risks of delirium, pressure injuries, and the metabolic impact of polypharmacy. How do we prioritize these competing needs? We do it through evidence-based nursing care plans. These care plans require us to ask, is this confusion a sign of a new urinary tract infection or a side effect of a newly prescribed analgesic? This is where the critical thinking questions become our most valuable tool. In the geriatric setting, patient safety is the ultimate priority because the physiological reserve of our patients is significantly diminished. A minor decline in one system can lead to total system failure. Regarding the next-generation NCLEX case studies mentioned here, these are the gold standard for preparing you to recognize subtle cues. In an older adult, a silent myocardial infarction might present as simple fatigue or a fall. The NGN format trains your brain to analyze data and prioritize hypotheses in real time. You are not just learning to pass an exam, you are learning to save a life that communicates in whispers rather than shouts. Clinical Pearl. Always remember the geriatric mantra: start low and go slow with all new medications. However, when you notice a sudden change in mental status or a new onset of confusion, you must move fast. Always assume a sudden change in cognition is a physiological emergency, such as hypoxia, infection, or drug toxicity until proven otherwise.
The primary focus here is the transition from general clinical knowledge to the specialized, evidence-based practice of geriatric nursing. As we embark on this journey, we must recognize that caring for the older adult is a high-stakes discipline, where the standard textbook presentations of illness often vanish. Why is a specialized compass necessary for this population? Because in geriatrics, we are navigating a landscape of diminished physiologic reserve, where a minor infection doesn't present with a high fever, but rather with a sudden, debilitating state of confusion. You are moving beyond the basic task-oriented mindset of a student to become a clinical advocate. This means understanding the intersection of normal age-related changes, such as decreased glomerular filtration rates or reduced cardiac output, and how those changes dictate our nursing interventions. For example, why must we start low and go slow with new medications? It isn't just a catchy phrase, it is a safety mandate based on the altered pharmacokinetics of the aging body. In this clinical scenario, your most powerful foundational tool is the functional assessment. While a younger patient is measured by the resolution of a specific symptom, the success of geriatric nursing is often measured by the preservation of independence. We are looking for the why behind the data. How does a decline in mobility today impact the patient's risk for skin breakdown or pneumonia tomorrow? NCLEX focus. Always prioritize safety and patient autonomy. When you see questions regarding the elderly, look for options that address the prevention of geriatric syndromes, like falls, delirium, and polypharmacy. These are the primary threats to an older adult's survival and quality of life. Clinical Pearl. Never assume that confusion is a normal part of aging. In the clinical setting, an acute change in mental status is delirium until proven otherwise. Your first nursing action must be to investigate physiological triggers, such as hypoxia, infection, or medication toxicity, rather than simply documenting confusion due to age. The primary focus here is the critical transition from classroom theory to the complex reality of the geriatric clinical setting. Preparation is not just about memorization, it is about the safety of our most vulnerable population. Why is this preparation so vital before stepping onto the unit? In geriatric nursing, we are rarely managing a single acute issue. Instead, we are navigating the intersection of age-related physiological decline, chronic multimorbidity, and significant psychosocial transitions. When you review your notes, you must look beyond the surface. For example, why might a normal temperature in an 85-year-old patient actually signal a life-threatening infection? Because the aging hypothalamus often fails to mount a traditional febrile response. This is why your baseline assessments are the most powerful tool in your clinical arsenal. If you don't know your patient's normal, you cannot detect the subtle abnormal that precedes a crisis. NCLEX focus. Always prioritize assessment findings that represent a change from the patient's baseline. Remember, acute confusion or sundowning is not a normal part of aging. It is a clinical red flag for underlying issues like hypoxia, dehydration, or a urinary tract infection. Clinical Pearl. Use the teach-back method during every patient interaction. If an older adult cannot explain their new medication or fall prevention strategy back to you in their own words, the teaching has not occurred. And in geriatric care, a lack of understanding directly leads to rehospitalization.